Hello and welcome to the webinar. My name is Lily Catalano and I will be acting as moderator for today's coffee chat on reproductive health, a production of the National Healthcare for the Homeless Council. This session is being recorded. This is a 1-hour session with time for Q&A throughout. Below the presentation slide, there is a chat box for participant responses, questions, and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. If you are having technical issues, you can also contact the Council's office at 615-226-2292 and speak with Alyssa. The PowerPoint presentation and the recording of this webinar will be posted on our website, www.nhchc.org, within 72 hours. I'd now like to introduce our session speaker, Dr. Ginny Ryan, Associate Professor of Obstetrics and Gynecology, Affiliate Faculty in the Program in Bioethics and Humanities, and Core Investigator at the Center for Comprehensive Access and Delivery Research and Evaluation at the University of Iowa. Welcome, Dr. Ryan.
Thanks very much, Lily. It's an honor to be part of this coffee chat today, and I'm very grateful for my introduction to this organization. I'm embarrassed to say that I was not familiar with the organization until I was connected through a request for this coffee chat, so I'm really excited to now know about the organization, its good work, and resources. And I just want to mention that I'm trying to wear all my various professional hats today as both a healthcare provider for women's health, as well as I guess I would describe myself as a practical bioethicist. And then I'm also, as it's listed, a researcher at the VA here in Iowa City, looking at reproductive health issues in actually both male and female veterans. So that's my perspective that I'm bringing to this talk, and I'm excited to hear the different audience members' perspectives as well. So our overview of today's discussion, and again, I really do hope for a discussion as much as that's possible on this type of webinar structure, but we're going to be starting with a few audience participation questions just so that everybody gets to know who's in the audience today. And then I'll describe some of my learning objectives, which are really more aspirations for the discussion. And then I brought in 2 case studies to try to stimulate some further discussion. One's more clinical and one has more to do with research, and then with maybe some talking points after that. And then I've listed some of the wonderful resources that I found through the website for NHCHC. And then also some resources that I was more familiar with through the American Congress of Obstetricians and Gynecologists. There's really a number of resources on their website that are generally accessible to just to the general public and are also published and so are peer-reviewed. But the most pertinent ones are probably from the Committee on Healthcare for Underserved Women. And then I just have a few other resources listed as well. But again, I've been really impressed with how the HCHC and website has a lot of great, specifically on the reproductive health page, really great resources on lots of issues with regards to reproductive health. So I didn't certainly want to list all of those, but just point out that that's a great resource as well. So our first audience participation question, I'm just interested in knowing about everyone's professional positions. So educators and healthcare providers, but then a smattering of care coordinators, administrators, social workers. Wonderful. Well, thanks to everybody for for your involvement today. And then next, I thought it would be interesting to just see where everybody's working currently. Interesting. So all out in the community, it seems like not a lot of really nobody from private or academic medical centers, except for me, I guess. Great. Well, thanks for that. And then the final question for audience participation, and there is a option of no vote. I was just interested in knowing the kind of age range that we have in our audience today. Great. And it looks like we have 15 maybe total participants so far called in today. And I think everybody could see the results for those for the audience participation polls. So now we have a sense of who we are all representing. So again, as I suggested, these are just more than learning objectives, really. They're just sort of aspirations that I had for things that could come out of this coffee chat. And so I'm excited to engage in a discussion about both the unique reproductive health needs for homeless women, but also really the universal reproductive health needs for all women, and how they may we may find more universality than uniqueness in this discussion. I also think it's always important for me, and I know we should all be doing this every day, but to identify our own personal biases and blinders that may hinder our optimal care for women who come to us as patients or clients. Again, with my bioethics hat, and I think part of the reason I was asked to be on this chat, I think it's important to consider what are really the ethical principles that are underlying some of the issues that we'll be discussing, and how we develop best practices when we care for women. And then finally, I think it would be great to continue a discussion of best strategies to provide both evidence-based but also patient-centered reproductive health care, especially for our homeless patients. So again, to start the discussion going, I wanted to bring up this case. Excuse me. And this case is actually, you'll find a more extensive version of this case in one of the listed resources, the PDF that's called Adapting Your Practice, PDF that's listed in the resources. And this case, in case you want to see or refer to it in the future, I thought it was, when I was looking for cases, I thought this was a great illustrative case. And it is on page 3 of that Adapting Your Practice PDF. And I'll just read through it real quick, and then we can have some discussion. So this is a 27-year-old Gravida 2 Para 0 woman with a history of using condoms and oral contraceptives, who presents for a Well Woman exam as part of her residential recovery program. As far as social background goes, she's a rural town high school graduate. This is certainly something that anecdotally that really struck a chord for me here in Iowa. She has a history of sexual and physical abuse in her childhood and moved to a large city to become a dancer. She began using alcohol and cocaine as coping mechanisms, which gradually moved into smoking crack. She recently began using heroin. Her addiction led to becoming homeless. At this visit, she's 30 days clean for the first time since she was 18 and is stable in residential treatment. Her medical history is significant for pelvic inflammatory disease. She's had 2 abortions. She's been diagnosed with PTSD resulting from her history of abuse. And she currently participates in a trauma-informed women's recovery group where she receives counseling for PTSD. So now I'd really love to turn it over to the audience and get some responses from you guys.
So in hearing this patient's background, what are your biggest concerns? You all can use the chat pod to type responses. So one concern is, when was she last tested for STIs? What other concerns come to mind? What support system does she have outside of counseling? Is she sexually active? Concerns about her insurance coverage, access to a primary care provider, access to prescriptions. How is the housing situation coming along? How will her addiction be dealt with in preparation? How has her history of trauma impacted her access to reproductive health care? Is she in a relationship? How long is she residing in the residential treatment facility? Does she have access to a support system once she leaves the facility? And what matters to her today? Are there outpatient addiction services? Any other concerns that come to mind? Would it be possible for her to undergo a pelvic exam with regard to her history of PTSD and abuse and her desire for future children or pregnancy? So lots of thoughts and questions coming up. Jenny, do you want to go into any of these in more detail?
Yeah, these are great. I mean, I can tell from these responses and suggested questions that most of you do work out in the community and realize how important it is for these women to have the social support in place, and whether that's residential support, other social support networks, access to care and to a support system and to substance use treatment. That's wonderful to see. I also like seeing the responses, just asking what matters to her today, what are her concerns, very patient-focused, and I think that is something that we all need to take into our encounters excuse me, with our patients and clients. There's a lot going on in her history, a lot of potential medical issues, but it doesn't really matter so much what our agenda is for her, but where she's coming from and what her desires are for that visit. And when you look at everything that she's been challenged with, I think it's just remarkable that she is seeing you, that she's made it into some amount of care, and so I think a lot of congratulations and support for that important step should be given as well. And I see that a number of people work in Title X clinics, and one of my concerns in reading this is, in reading this case in the handout when I was going through it, was just kind of what our situation is right now when it comes to funding for Title X clinics and access to safe abortion, again, especially for rural women. And so I don't know how many of you are, in rural versus urban settings, but this is a real problem across the country, and especially in our rural areas. It also struck me that this case, there may be an assumption that this woman is heterosexual, and I think that that's an important thing to identify and tag in this type of situation, despite the fact that she's been pregnant and uses condoms and things like that, especially in situations where there's been substance use and homelessness. It certainly does not, heterosexual intercourse does not necessarily equate with sexual orientation. And we know that our homeless patients, our LGBT youth, are more likely to be homeless and with a higher risk of sexual assault history and PTSD. So I think that was something that I tagged for myself in this case study as well. Of course, at the same time, that doesn't mean that we don't need to be considering, the need for contraceptives, because, obviously there may be bisexuality, or there may be future assault or future heterosexual sexual activity, regardless of sexual orientation. So, exactly, and somebody commented survival sex, exactly. So, something to tag as a potential bias, but also to realize that contraception is still very important. And I love the fact that somebody brought up the issue of, will it be possible for her to undergo a pelvic exam, and really questioning what we can do for our patients that may not require a pelvic exam. I work with a lot of adolescents, and I think there's this default feeling like if you're at the gynecologist, you need to have a pelvic exam, but there's really a lot we can do that, whether it's STD testing, whether it's a self swab for a wet prep, things like that don't require a pelvic exam. And so I think that's a really important thing to identify as well. Just looking for any other comments? The next slide has some other points that I can bring up as well, but any other comments before we move to? So, the evidence would suggest, and I'm sure that those of you out there working day to day with this population of women can attest to the importance of these key components of healthcare in general and reproductive health care for homeless women. There's a really, again, if I can refer you to the Adapting Your Practice PDF, which hopefully many of you are familiar with anyway, there's a really nice introduction there on page 1 and 2 that talks about the increased risk that homeless women have when it comes to reproductive health, a lot of which came up in that last slide. So, increased risk of unprotected sex. These women tend to be more sexually active but less likely to use contraception, perhaps due to access, perhaps due to misconceptions, cultural understanding, ability to have anywhere to store their contraceptives, obviously cost. So unprotected sex and undesired pregnancy is a real risk, of course. History of sexual assault, much higher, obviously, in the homeless population as well. And along with the unprotected sex comes the risk of HIV and hepatitis. There's a stat in this intro that talks about that less than 1% of homeless women currently use condoms. So again, that puts them at quite high risk for HIV and other sexually transmitted infections. So that was an important focus that many of you had in the with that case on the last slide. And I think our national rate in the United States is about 50% of unplanned pregnancies, but those aren't always undesired pregnancies. That's not an equivalent. Nevertheless, homeless women have about twice that rate of unplanned pregnancies. So access to contraception is a huge issue, and given the increased risk of pelvic inflammatory disease, and thus the increased risk of ectopic pregnancy, that can be a real medical emergency in these women. We now understand that pap smears are not needed as frequently as we used to say, but still annual visits are still encouraged, and women more sexually active are more likely to have a high-risk form of HPV that is going to require typically more monitoring for cervical cancer screening. And again, as I mentioned as well, I think we always have to keep in mind that we can't assume heterosexuality by just our general bias or by a bias by sexual activity, and realize that our LGBT population is out there higher in the homeless population than in our general population who are housed. So what I liked, I don't know how many of you have the PDF available to you, but there's a great comment in there on page 2 that says clinical practice guidelines for the care of people who are homeless are fundamentally the same as those who are housed. And I think that's really important to identify. It goes on to say, nevertheless, providers who routinely serve homeless people do recognize the need to take living situation and co-occurring disorders into consideration. So the key is that we should provide the same, quality of care and be cognizant of the same issues and factors related to reproductive health in all women, and yet have to be, aware of the context. I thought that was a great point. So just to point out also, in your resource list, there's the Adapting Your Practice is a larger document where the actual practice adaptations begin on page 4. But there's also listed in your resources the abbreviated guidelines, which is a 2-page document, and does a great job of just summarizing the key parts of a history and physical testing, and some of the keys of just things like having a non-judgmental attitude, and things we don't always think about when it comes to reproductive health care, but should be for all women. Things like oral health care, which can be a real issue with regards to prenatal care and fetal health risk. And then they make the important point here, which I loved again, as pointed out before, that physical exam, we don't have to do physical exams to initiate contraception or to do a lot of diagnosis and just initiation of a trusting relationship. So, pelvic exams really can be deferred, and you have to really think about what the importance is before you require this of patients or encourage patients to undergo this. And I think about the way we take care of women in our VA, chaperones always, including for pelvic ultrasound, and just an assumption that women, unfortunately, an assumption that women have had a history of sexual trauma, I think is an important way to go into these relationships with our clients and patients. So take a look at that if you haven't already. I think it's a wonderful document that covers a lot of important issues with reproductive health care, and especially key things about contraception and things we have to think about in that population. So with this list of keys I have in the bullets, is there anything that I'm missing? Any other keys that you would say to the best possible reproductive health care for homeless women?
So culturally competent was another key to care for homeless women that was shared.
I'm really interested in hearing thoughts and tips and from our community care providers in the audience, because I often feel like in an academic medical center where we practice, we are not, unfortunately, we should be, but are not often on the front lines of the homeless population. I think the other thing that I sort of failed to mention, and I feel like from our standpoint here in an academic center, for example, is, I think it's important to find a provider champion, and I'm sure that that's what audience members have found. But I think about here at the University of Iowa, and I think about how we have, have our Title X clinics in the community, and at times we fight to make ourselves more accessible to the community, but oftentimes just rely on those clinics to take care of patients who require a sliding scale, or much more affordable contraception. But I feel like if you have the right champion, then there can be the potential to work together. And then that can help mobilize resources that may exist through grant funding or other kind of resources that the hospital or academic medical center may be able to bring to bear. And that can really help integrate quite nicely with community care partners. So I think that's something that I wanted to just bring up as potentially a best practice as well. All right, I don't see any more comments so we can move on to the next case. Lily, do you see anything else coming in?
I think we're ready for the case.
Okay. So the next case is sort of, I guess I transitioned from my last comment there. The next case is one of the ways in which we could potentially do a better job at integrating our community care with our academic resources, including research. to improve our evidence-based medicine and care, excuse me. So case 2, a VA researcher is designing a study of infertility and family building preferences and practices of United States veterans, would love to survey a representative sample of U.S. vets under the age of 45. The easiest way to do this would be to request a random sample of veterans listed in VADER, which is a VA directory, and recruit and interview these veterans by letter and phone. So I'd be interested in hearing your responses to this case.
So in the Q&A pod, think about how representative this sample would be, and is that important? Some comments already coming in that you'd need an address and a phone to receive the request to participate in this. And what might be a better way to accurately assess the veteran population? What ideas do you all have? A comment, I think any data is important. Is the researcher looking to improve these services? Who in the VA is providing these services now, and would it be a good idea to partner with them? Suggestion to screen various community settings for veterans who wish to participate, such as homeless shelters, churches, gyms, hospitals, etc. Jenny, anything you'd like to respond to?
Yeah, great. I appreciate I think that's right on, the comments about you need an address and a phone, and that was kind of what I was trying to get to, which is the issue of sort of the default, perhaps easiest way to do a lot of a lot of especially broad national representative, so-called representative sample work on anybody is really to try to do it by phone or by mail with recruitment. Certainly less time-consuming and resource-consuming, but when we're trying to assess an important segment of the population, the homeless population, or intermittently homeless population, or population that tends to move around, we are not going to be capturing those people in our research, and so that has been a problem in the past and continues to be a problem. I thought that was particularly relevant. This particular study is particularly relevant to the VA population, both because there's an increasing interest in reproductive health research in the VA, because of the increasing, not that reproductive health is only a female concern, but because of the increasing population of female veterans, there's appropriately an increased interest in reproductive health for those veterans. And yet there's sort of a bias to consider that certainly family building, perhaps infertility, those shouldn't be concerns for our homeless veterans. There's this bias out there. And so I appreciate the comment also that one of the audience members made on a previous slide about her desire, a patient's desire, a client's desire for future children or pregnancy. I think that some people may look at that question in response to a homeless woman, an interaction with a homeless woman, and think that that should not be on her priority list. Why is that? Why is it something I need to spend my time on? And I think that that's just an unfortunate attitude. But I have run across it, and certainly both in the research world and the clinical world. So I wanted to bring up that it's kind of a perfect storm of important issues that are unfortunately not being raised or researched adequately in the homeless veteran population, or probably in the general homeless population either. On the other hand, it is difficult. That's part of why I wanted to query the audience about better ways to accurately assess a veteran population. when it comes to research. It's very difficult, and it really has to be community-based, as was pointed out. It's difficult to do any, longitudinal research because typically there's a consistency required there that is often not possible for our homeless population. And so it's difficult but worth doing, I think. And it's important to access resources that are out there, so I appreciate that comment as well. I think the VA, for example, has an important group of research networks, and so this would have to be, rather than being from sort of one location doing everything by phone, you would have to rally. They have sort of a rural health research network, a women's health research network, and they have a network where you can rally others interested in homeless veterans to do that kind of surveying. But you do have to alter your methodologies, and I think that's an important thing to realize. And again, especially for reproductive health, I think we also want to be very carefully assessing and being very inclusive in how we assess things like sexual activity, orientation, gender identity, and desire for future family building, and risks for, I think we have to open it up and think about a little bit more qualitative research instead of trying to fit people into boxes that we've put them in the past. And so I'm kind of interested in seeing if anybody has feedback too on what important insights might be lost if, say, homeless veterans or our homeless population is not included in research on, say, family building.
One comment, the homeless population is often under or not represented at all. Being inclusive and recognizing intersectionality is huge and then builds trust in the patient.
So I'm just going to go on to the next slide and bring up a few points, again, I think that are key to providing accurate and optimal health sciences research on homeless women. And there's an interesting conversation out there that about how women in general and incarcerated women, homeless women, incarcerated people, homeless people, are considered in the scientific community, in the research community. And in the past, they've been described as vulnerable. And there's a move afoot to change that term. And I think it's an interesting conversation. The ACOG Ethics Committee has published a piece suggesting that women in general should be described as potentially scientifically or medically complex rather than vulnerable. I think the point behind the label of vulnerability, if one can think of it as a potential positive, was to try to improve representation by these so-called vulnerable populations, like women were equated with children. But I guess the point, if we think on a positive note, was to better represent these populations in the research world. But again, certainly I think it's an interesting conversation when it comes to incarcerated folks as well. There certainly may be some power vulnerability, but I just wanted to bring that up in a discussion of research on the homeless population. I think the key really for research projects is to be as multidisciplinary as possible. Again, that's a key to clinical healthcare as well, but we really need to be reaching out to our partners in social work and anthropology and sociology to really get a sense of how to ask and what to ask and how to hear voices that need to be heard. There's a particular type of research that you may be familiar with that's called participatory action research that I think is particularly valuable for research on homeless women and in community settings. in general, to best hear people's voices. And it basically emphasizes participation in action. Basically, we try to understand the world by also at the same time changing it collaboratively with our community partners and reflecting on what we see. So it's really a collective experience, which is very different from what we classically think of as research, but a really exciting form of research that I think is particularly, again, valuable when it comes to working with our homeless population. And also I'm interested in if anybody has thoughts on how they might identify the important, again, the ethical underpinnings of what we're trying to do by optimizing our care and our research for our homeless women and their families. Is that, why are we trying to do this?
Some ideas that have been shared to avoid marginalization, to increase the body of research data across the wider spectrum, to be able to tailor healthcare practices toward best practices for individual segments of society in a differentiated approach.
That's wonderful. I like that. Thank you. I do think we don't know. We make assumptions if we don't really know, if we don't talk to our patients and our clients to know how to best serve them. And research is just doing that in a structured way and making sure that we try to, in structuring it, make sure we try not to lose any voices along the way. And I always think about, why. There's a number of reasons, whether it's, personal or professional, but, what are the sort of principles that are bringing us to trying to provide a just healthcare system for everybody that we deal with, to treat everybody, equally, if not the same. And I think just, when it comes to ethical principles, you think about justice and everybody receiving what is due to them. It's one of the, core principles of ethics and bioethics. I think you can also just obviously bring beneficence into it. It's sort of our professional obligation to improve the lives and the health of the community, and in making sure we're doing that in a multidisciplinary, patient-based and evidence-based, patient-focused and evidence-based way. That's how we can best benefit our population. And as providers and community partners, that's our sort of ethical responsibility. And obviously we often take professional oaths to do that. So there's a number of places you can look for beyond just your own gut telling you that it's the right thing to do. There's a number of places that you can look in, in philosophy and ethics to try to prove your case that this is the right thing to do. So we only have, I think, maybe 7 minutes or so left. I've listed, again, some of the resources here, the web links, that I think, again, have some really valuable resources on there and are all accessible to the public. The WHO medical eligibility criteria is something I use almost every day, certainly every day I'm in clinic. Very helpful and very user-friendly way to look for what might be appropriate for some of the more medically complex patients that you may have who really do need, good contraception. I think one of the biggest things we can do as gynecologists is to try to make our long-acting reversible contraceptives available more widely. There's clear evidence that is an effective public health effort. But so if you're ever wondering, well, my patient with hepatitis, can I give her this or that? What about my patient with, cardiac disease or et cetera? That's a wonderful place to go. I've attached the On the Street article, which is a really, I think, great assessment of a potential agenda for LGBT youth, homeless youth. There's the link, but also, again, I've attached that. Well, I didn't, but it's been attached. And then finally, these are all accessible through that link on the previous slide, but these are just some of the most, I think, pertinent and nicely written committee opinions from the ACOG Committee on Healthcare for Underserved Women. And so you can access those if you're interested. And I think that's all the slides I've got.
We have a few minutes left to do some more Q&A if there are other questions you've got or other topics that you'd like to raise. You can please use the Q&A pod below the presentation slides to type any questions that you have. A question asking for the link or web address for the LGBTQ on the Street article. Is that?
That's on our resource list. It's the LGBT Homeless Youth Policy Agenda PDF.
And that will be posted with the PowerPoint and the recording on our website after the session. You can also download it here. If you look in the resources pod and click on that, it'll give you the option to download the file right now. Well, thank you all for joining the Coffee Chat on Reproductive Health, produced by the National Healthcare for the Homeless Council. This session will be archived on our website at www.nhchc.org within 72 hours. A link of the archived webinar will also be emailed once it's posted to our website. At the close of this webinar, an online survey to evaluate the session will automatically open in your web browser. Please complete it so that we were able to improve your webinar experience. Please also join us on May 10th for another coffee chat on competency and decision making, and again on June 7th for a coffee chat on end-of-life issues. Visit the NHCHC website to register, and you can also view other upcoming webinars and other educational products. Thank you. This meeting will now be closed.